Basically, for the medical management, it's really a summary of all the things that we have gone through. Remember, for you to be able to manage a child who has bacterial sepsis, you need to be able to take a thorough history, look at all the signs and symptoms in the examination to guide you to make that diagnosis. The biggest challenge we had, and why we're sharing these cases, is because at the initial time of presentation, this child presented as a hyperhemolytic crisis. The child presented with deep jaundice, with high fevers, and we kept asking ourselves, where is the focus of this infection? So we actually delayed to make the diagnosis of osteomyelitis, and that's why we're presenting this case. Another thing that's important is to have a high suspicion of a focus of infection in a child who has sickle cell disease. Kathy elaborated that because of the lack of function of the spleen, there's a high risk of bacterial sepsis. This was a 9-year-old, and someone talked about the issue of, do we still need Pen-V in patients in sickle cell disease in Uganda? Remember, when you give Pen-V in the management of a child to prevent sepsis, it's only useful in a child who is less than 5 years of age. Any additional use above 5 years of age, there is no additional benefit. Your benefit would actually be with revaccination, so you should think about that. Another thing that's important to note is the issue to do with bacterial sepsis and comorbidities with malaria. You saw clearly in the presentation by Dorothy that this child still had 3+ malaria. So there is a high association between malaria infections and bacterial sepsis in these children. So you need to always reevaluate your child. So if the child comes in with a fever, ask yourself, where is the focus of infection? If you don't know, keep asking, keep examining, keep looking out for the silent features that point out. You would also note that Letitia was asking about the X-ray. So the X-ray had 2 features. One was the avascular necrosis, and at the neck of the femur is where you could see features of chronic osteomyelitis and not acute. So worldwide, in terms of management of acute complications of sickle cell with regard to bacterial sepsis, there's a lot of evidence that is there. At the same time, there's a lot of consensus, because we deal with children who have sickle cell disease and have various morbidities. And when you think of the implications, do you treat a child who comes in with fever or don't you treat? So the first thing that you want to know is this child so sick that they cannot go home with an oral antibiotic? And if they are so sick, then you need to hospitalize. Within our setting, I would propose or even recommend that any child who comes with a fever above 38.5 degrees, you need to hospitalize and investigate. And the first thing was mentioned, a complete blood count. If you don't have it, please remember you hit hard and you hit fast. You'd want to cover with a broad spectrum antibiotic. Most times it's a cephalosporin. If it's not available, then you have alternatives. Think of the organisms. We're thinking of strep, we're thinking of staph, we're thinking of salmonella, the common organisms that we have. It's quite interesting to note that in some of the studies that were discussed by Elizabeth, that only about 25% of these children who had sepsis were able to grow bacteria. And it's not uncommon, because the techniques we use are quite difficult in terms of identifying this bacteria. So even if you don't see the bacteria, don't think you don't have it. The other thing, of course, is assessing the risk. 2-year-old versus 4-year-old versus 9-year-old. Who is more likely to die due to sepsis in sickle cell? Is it a 2-year-old, a 5-year-old, 10-year-old? So the age of the illness can help you to determine the risk for severity in the illness. The younger child would have a higher risk for bacterial sepsis compared to the older child. So it means that you need to look at several things. Within our evaluations, please look at the reticulocyte count. You want to see the function. Blood culture, urine culture was talked about. And if you have any focus of infection, try and get that pus or liquid out and test for it. because it will help you to determine so many things. We had a big problem with this child. You saw the antibiotic use, because the first time we did the culture, every single thing that was tested, the child was resistant to it. So that's why you found there was a mix between the pizza and the augmentin, the ceftriaxone, and eventually the meropenem. Blood transfusions. Children who have bacterial sepsis, there is no clear indication for a blood transfusion unless you have a primary reason. This child had a severe anemia of up to 2.6, then you would consider a blood transfusion. If this child had a diagnosis of acute chest syndrome, then you would consider a blood transfusion. But primarily bacterial sepsis, you may not need to have a blood transfusion in your plan. Another important thing that you would want to think about is, what can we do within our setting? We do have challenges when it comes to the use of antibiotics, so please keep in mind when you have a child who has a bacterial sepsis, if ceftriaxone is not available, then your next choice will be cloxacillin and gentamicin, because you'll be covering a broad range of bacteria. Another important thing that you need to look at that wasn't talked about is the issue to do with meningitis. So we are talking about osteomyelitis, but this child could have had a meningitis. Any altered level of consciousness, think about doing your LP to try and also exclude it, because you're basically looking at a septic screen. Lastly, to answer one of the questions, why was the child bleeding? This child had DIC, disseminated intravascular coagulopathy. So that was the reason why the child was bleeding, just to wrap up on some of the questions. When you're managing these children, please keep in mind that at the time of the diagnosis, you have to keep evaluating this child. Don't be happy when found out that this child has osteomyelitis. The next review, you reevaluate and have a plan. Make sure that your plan is able to guide you on improving this child's condition. And don't be afraid of making new diagnoses, because that's one thing where I think we need to improve on all the time. The child has malaria, you treat the malaria, the child gets better, the child has a fever, then we have resistant malaria. You've heard that before. Actually look for another source of infection. Fluid management in these children. It's always important that you must give maintenance. And the maintenance will be determined by how much this child is losing. In addition to that, you need to calculate for any excessive losses in this child so that you're able to maintain and rehydrate this child. Because continuous hypoxia, breakdown of cells can worsen the condition of this child. And I think as we come to the end of the talk, I would just want to emphasize one or two things that have been noted. That when you do have a child who presents with bacterial sepsis and you cannot find a focus of infection, you need to think of osteomyelitis as a primary secondary problem. What do I mean? Primary in the sense that it might be the cause of why the child has a fever, but you have not picked it. Secondary is because it could be as a result of the fever. I hope that's not confusing. Think of your fever as your bacterial sepsis and think of the focus of where that fever could have originated from. And always remember to assess the children for comorbidities, and especially the clear association we have between bacterial sepsis and malaria infections in our setting. Thank you all for listening.